Friends, let's see the relationship between the surgeon and the surgical pathologist. Surgeons are the providers of the specimens to the surgical pathologist. Thus, there are some expectations of the surgeons from the pathologist. Similarly, there are some expectations of the pathologist from the surgeon. And let us see what they are. I'm Dr. Mithilesh Chandra, a surgical pathologist, and I have been doing surgical pathology reporting since 1975 when I joined National Institute of Pathology, Safdarjung Hospital, New Delhi. I established my own histopathology, cytology, and immunohistochemistry lab 26 years back in 1994 in Noida, Uttar Pradesh. And I have the honor of being the first lab in North India to start immunohistochemistry in the private sector. So let us talk what the surgeon expects and what the surgical pathologist expects from each other. Both are partners in the patient healthcare, and they have to fulfill each other's requirement to achieve satisfactory patient healthcare. And their relationship is like girlfriends or boyfriend. They are partners, they have to do their best, they have to show their best. To be happy together, both have to understand each other's expectations. Like here. Now, a surgical pathologist receives specimens of all sizes and all kinds. And if there is no cooperation from the surgeon, one can make the diagnosis which are absolutely upside down. Here we have like breast. If the cancer of the case of the breast carcinoma has been operated before, or the lumpectomy has been done, or neoadjuvant therapy has been given, and that is not mentioned in the papers, then the report can be very, very different, and it can lead to problems. Similarly, here is the case of carcinoma gallbladder. One has to suspect and do the radical resection and with the lymph node dissection if they are suspecting carcinoma clinically. So clinical suspicion is very, very important. Here is a case of gallbladder again. Here is ovarian carcinoma, and here is intestine, and here is intestine again. So we find various types of specimens, and many times we find without notes. Sometimes it is not even written from where the biopsy has been taken. Leave aside the diagnosis or suspected diagnosis or the operative findings. So, like a couple when under wedding takes vachans, we have to take vachan or promises from each other to do things best for the patient healthcare. Now, the first promise by the surgeon. When pathologist receives a specimen, he expects for the following from his partner. A pre-surgical clinical photograph be taken of the visible and palpable masses and provided to the pathologist. That will help in reaching the correct diagnosis. Here, it is so simple to take photographs these days. Now we don't even need these SLR cameras, we can take with the help of the mobile. And if we have such a photograph with us, it is not difficult to diagnose a case of dermoid cyst of the bridge of the nose. So we don't even need to look at the slide. So helpful are the clinical photographs. Then proper clinical details related to the location of the mass, the duration, the symptoms, and these should be written in legible handwriting, not in the scrolling handwriting. They should be very clear, like in this TRF or test requisition form. If the mass is not superficial, you cannot take a photograph clinically. Then per operative picture shall be taken and should be provided to the pathologist during the surgery, so the pathologist knows about the involvement of the surrounding organs. Then cancer specimens should be properly oriented and labeled with the help of the sutures. A diagram drawn additionally will help both. Now here we have a diagram of the specimen of carcinoma of the tongue, which has been labeled with the help of stitches, and it becomes easier to uh, label the margins during glossing. We should avoid situation of GIGO, that is garbage in and garbage out. If we provide garbage during our test form, the report will be again garbage, which should be coming out from the computer. The samples should immediately be fixed in 10% formalin, not approximate dilution, but by measure. A specimen will be put in a wide mouth jar. That is the promise should be taken by the surgeon. And he will not squeeze the specimen into the container, because after fixation, the specimen becomes hard and container has to be cut or broken to take it out, and it becomes out of shape. Now here is the right way to put the specimen in the jar, which is wide mouth with adequate amount of formalin. And here is the specimen. It should not be done. It has been squeezed, large amount of specimen has been squeezed in a small bottle, which is not wide mouth. This situation should be avoided. Otherwise, the specimen will get crushing artifact and the whole morphology or architecture of the specimen will be destroyed. Amount of formalin should be minimum 20 times the volume of the specimen for proper fixation of the tissue. The situation should not be like this, where half the specimen is jetting out of the formalin. Rather, it should be like this, that the whole specimen should be dipped in the formalin. If the tissues are sent in separate containers, the surgeon should promise that I shall label each container separately so that it matches the information on the tissue requisition form, test requisition form. Like here, if we have 5 specimens, they should be in 5 containers and they should be labeled separately like A, B, C, D, and E. And this information, what is in A and what is in B and C and D and E, should be written on the test requisition form. Then the surgeon should take a promise that I shall not cut the specimen haphazardly. If necessary, will make one straight cut only. Otherwise, the architecture of the specimen that's very distorted and it becomes many times difficult to make out what is what. Then I shall try my best to not leave OT before the form is filled and the specimen is properly put in formalin and labeled. So this part is the responsibility of the surgeon, because it is the surgeon who is ultimately responsible for the report, and the report depends on how the specimen has been received. For some reason, I have forgotten to provide some crucial information about the patient or specimen. I will not hesitate to pick up the phone and inform my pathologist. This is promised to be taken by a surgeon. So these days, mobile is in the hands of everyone, and it is so easy to call up your colleague or pathologist and give the information which has been lacking on the test requisition form. Kindly remember, an autolyzed tissue is a crime against the patient. So no tissue should be autolyzed. Do not leave things to the imagination of the pathologist, as it may lead to disaster. Please provide your phone number on the form. Do not ask RMO to fill the test requisition form. Otherwise, the information given is absolutely either nil or inadequate or wrong. I remember the days when we were interns, we were told to take the blood from the ward to the pathology department. And when we reach the pathology department, the pathologist will ask the history and will say, no, I don't know. I was given the specimen to deliver. So the pathologist will say, are you a courier boy or a courier girl or you're a doctor? Then we were so sheepish. We didn't know what to say. To let that situation not come. It is not RMO who is responsible for the patient, it is you who is. And it should be your ultimate responsibility to fill the form, to label the specimens properly so that you get the proper report. Time is spent in this whole procedure is your investment. It is not waste of time. You may be busy, but sometimes that may lead to disaster. So let that situation not come. And then there are some promises which are to be made by the pathologist also. The pathologist should take a promise that I will read clinical notes carefully and will discuss any discrepancy before proceeding with the gross cutoff. We'll take sections from all the label margin and will do crossing of the specimen as per the proper protocol. I will comment on all the prognostic markers which are currently used in reporting of that particular specimen. Will provide unambiguous report. Will not say benign versus malignant. One has to be clear whether it is benign or it is malignant. And if one is not able to make up mind, then one has to take help of parameters like immunohistochemistry, and one should advise that so that one becomes clear whether the lesion is a benign or a malignant one. And the report should be delivered by the pathologist within a stipulated period. Short turnaround time is expected from the pathologist because many patients are very critical and their treatment is delayed if the report is delayed by the pathologist. So one should make to give early report to the patient. And accuracy. In addition to speed, there has to be accuracy in the report, without which no report is worthless. So these are the promises which are to be taken by the pathologist. Thank you very much. Hope that we all will live by our promises. And thank you so very much.